Good morning. We'll go ahead and get started. My name is Larry Wright Jr. I'm the tribal chairman for the Ponca Tribe of Nebraska and the Great Plains Area Representative to the National Indian Health Board. It's my pleasure to welcome you to the Health Resources and Services Administration consultation session for the 2021 National Tribal Health Conference. Before we begin, please note that this session is being recorded. If you do not consent to being recorded, you are asked to drop off the session at this time, and we'll give a little bit for people to drop off if they so choose. Thank you. Thank you. As is customary, we'll start this meeting in a good way with an opening prayer. I've been asked to give that prayer. Oho wakanda, dena da haudani, ombale wadaikte, HD wiblahan shidade, si dego wongi de gatikte, wiblahan shidade, ponkangadi, bluga, donwa gidaga, neonshinga, ukedi, wongi de ekitahan walombaga, neonshinga, wanoshe hidi HD daida de kumblega, idando udake ahigi odaikte adidahan degon deno dahan udani. Great Spirit, it's good to pray to you. We thank you for this day. Say special prayers for my Ponca people, for all of our tribal nations, our veterans, all those that work on behalf of all the tribal citizens for the health, prosperity, mind and body, spirit. We bless all those, ask for blessings for all those that are here today to take a part of this session. All those that work on behalf of our Indian people. We thank you for all these things. Please help give us the strength to carry on through this tough time of dealing with COVID and all the issues that face our people. Ask for strength and courage for all those that fight day to day on the front lines to help our people. Gatega, Wiblahan, Sheno. Thank you. During this session, we will be speaking with Diane Espinosa, Acting Administrator for HRSA, and other key leadership from the agency. We appreciate the engagement with Ms. Espinosa, and we look forward to discussing a host of issues that are important to our tribal nations. To lead this session, I'm also happy to be joined by NIHB alternate Oklahoma City area representative, Ms. Melissa Gover.
Thank you, Chairman Wright. The Health Resources and Services Administration, HRSA, is an agency of the U.S. Department of Health and Human Services. HRSA is the primary federal agency for improving health care to people who are geographically isolated, economically or medically vulnerable. We have many important topics of discussion for today's tribal consultation. These topics will include HRSA's Health Center Program Uniform Data System and the scoring of the health professional shortage areas. We look forward to meaningful engagement and discussion today, and we welcome the opportunity to strengthen our partnership. As tribal leaders, we appreciate the time we have with HRSA leaders so that we can share our guidance and recommendations on a variety of issues. This is a dynamic time, and we want to ensure that tribal leader perspectives are heard, understood, and incorporated in the agency's work. In just one moment, I'm turning the floor over to Michelle Allender, Director of the Office of Health Equity, to provide a welcome and opening remarks. After these remarks, Ms. Diana Espinosa and other key leaders will provide some brief updates and additional information. After that, we will begin the open discussion portion of this tribal consultation. Like other tribal consultation sessions, we will follow tribal protocol and invite our elected tribal leaders to make comments first, share recommendations, and ask questions. Once our tribal leaders have had a chance to speak, we will open the floor to other members of our audience. And now, to provide us opening remarks, it is my pleasure to introduce Ms. Michelle Allender, the Director of the Office of Health Equity. Ms. Allender, it is so good to have you with us here today. Thank you, Ms. Espinosa, and the rest of the HRSA team for making the time to be with us for this important tribal consultation. I'll now turn the floor over to you, Michelle.
Thank you very much, and good day to everyone. It's my distinct pleasure to welcome you to today's 2021 HRSA Annual Tribal Consultation. I'd also like to extend a special welcome to newly elected tribal leaders who are joining us for the first time. My office serves as the principal advisor across HRSA bureaus and offices in matters related to health inequities, priority populations, health literacy, as we work to reduce health disparities so that communities and individuals can achieve their highest level of health. HRSA has enjoyed a long-standing and productive relationship across Indian country and looks forward to continuing that work. HRSA is committed to increasing access to quality health care and achieving optimal health overall for all American Indian and Alaska Native populations. For the past 11 years, much of this work has been done through my office, which has also worked diligently to strengthen the cultural competence of HRSA's project officers and staff who work directly with Indian country. Effective October 10th, HRSA's tribal health work will be conducted through the newly formed Office of Intergovernmental and External Affairs under the leadership of Natasha Kaloris, whom you will hear from shortly. As always, we look forward to hearing from you on national, cross-cutting issues and hearing your perspectives and priorities for your communities, even as my office passes the baton to HRSA IEA, to continue and to amplify the foundation set forth to improve lives for the better in Indian country. It has been a tremendous honor working with all of you, and I will now turn things over to my colleague, Natasha Kaloris.
Thank you very much, Michelle. Good morning and welcome to the tribal officials attending this consultation. Your advice and recommendation is valued as HRSA advances our work within Indian country. My name is Natasha Kaloris, and I'm the director of HRSA's Office of Intergovernmental and External Affairs, or HRSA IEA. On behalf of our team, we are honored to join you at the 2021 HRSA Annual Tribal Consultation. As a brief introduction, I worked in local public health in Michigan for nearly a decade, serving as the director of the Saginaw County Health Department and a HRSA grantee. I had the pleasure of working and partnering with the Saginaw Chippewa Indian tribe to address substance use disorder. Since joining HRSA in 2010, I worked in our policy office and maternal and child health bureau before coming to the Office of Regional Operations, which is now HRSA IEA. You will hear in a moment from our acting administrator, Diana Espinosa, about the evolution of our tribal affairs portfolio in response to your input and HRSA's commitment. The alignment of tribal affairs in HRSA IEA enables us to leverage both national and regional relationships with tribes. It also mirrors the Department of Health and Human Services Office of IEA. I reaffirm our commitment to respect tribal sovereignty and honor our government-to-government relationship. We strive to improve the health of American Indians and Alaska Natives in partnership with you. I'd like to thank Michelle Allender and Captain Elijah Martin for their leadership in tribal health affairs over the years and look forward to continued collaboration with them. A special thank you to Captain Carmen Skip Clellan, who will lead our efforts moving forward and brings tremendous expertise. And most importantly, I thank you for your dedicated leadership in Indian country. HRSA IEA has 10 regional offices throughout the country, with a headquarters office in Rockville, Maryland. Our work includes core functions such as external affairs and outreach, strategic intergovernmental partnerships, and bi-directional communication. Specific to tribes, we collaborate with HHS regional directors and regional tribal leadership in planning consultations and following up on HRSA issues. In 2020, we engaged with nearly 200 tribal leaders and represented HRSA in all annual regional HHS tribal consultations. Regions also provide technical assistance on key topics, such as HRSA grants processes and programs to help bring more resources to tribes. Our partnerships have been effective. As just one example, our Region 1 office, which serves the Northeastern states, built a trusted partnership with the leadership of Wabanaki Nation. Our region provided ongoing technical assistance on the federal funding process and shared HRSA resources for substance use disorder treatment. Through this partnership, the Wabanaki tribes successfully received their first ever HRSA grant in 2019, a $1 million Federal Office of Rural Health Policy Planning grant, which supported the development and opening of the Wabanaki Public Health and Wellness Center for Healing and Recovery. For COVID-19, the Wabanaki tribes received $300,000 in 2020 to support prevention and response efforts. And most recently, in 2021, they received $1 million from HRSA's community-based workforce for COVID-19 vaccine outreach. We are truly honored to work in collaboration with you. I encourage you to connect with Skip and the Tribal Affairs team, as well as the regional staff near you, to learn more about our work and how we can support you. Thank you again for the opportunity to connect with all of you today. I look forward to meeting with you in person one day soon. And I will now hand it over to Acting Administrator Diana Espinosa.
Thank you, Natasha, and thank you, Michelle. Good morning, everybody. And thank you so much for joining us. It's really my pleasure to be with you here today. As many of you know, well, my name's been said many times. I'm Diana Espinosa. I'm HRSA's Deputy Administrator, and I'm also currently serving as the Acting Administrator. And I've been with HRSA for about 13 years, working on a wide range of issues, including many of the ones that are of interest to tribes in particular. And during my almost 9 months as Acting Administrator, I've taken several actions to strengthen and expand HRSA's relationship with tribes, which I will touch upon in my remarks, but look forward to more opportunities to hear from you about what we might be able to do to support you all and engage with you all in a meaningful way. I want to commend your leadership and commitment to providing care and services through Indian country and to the nation's underserved communities. As we all know, that's always a challenging task, but especially so with the pandemic and all the challenges that it's brought over the last year and a half. This morning, I also want to extend a special thanks to Chairman Larry Wright from the Ponca Tribe of Nebraska for moderating today's session. In addition, Chairman Wright is HRSA's Great Plains Tribal Advisory Council delegate. So thank you, Chairman Wright, for serving on our TAC. And I also want to thank our host, Representative Melissa Gower, our longtime partner, the National Indian Health Board. The National Indian Health Board has supported us in several consultations, and we really appreciate the partnership. In addition to Michelle Allender and Natasha Flores, who you already heard from, I am joined today by HRSA's senior leadership and staff from each of our HRSA offices and bureaus. I think we do this so that we have the resources to address your questions or concerns, but also to demonstrate to you our commitment to working on tribal issues. This consultation is something that I look forward to, and I really very much appreciate being able to hear from all of you directly and hear, on meaningful issues that are important to you all, and also have the opportunity to share some updates about what we are doing. And so, you know, while certainly there's a lot of work to be done here, I really value our partnership and the progress that we've made together. Earlier this year, the president released a memo on tribal consultation and strengthening nation-to-nation relationships, which prioritizes tribal sovereignty and self-governance, along with trust and treaty responsibilities. And in line with the president's memo, I want to assure you that HRSA is committed to prioritizing and strengthening our government-to-government relationship. As part of this commitment, I'd like to just update you on the previously mentioned organizational change in HRSA that I believe is responsive to the feedback that many of you have provided in recent years for a separate office dedicated to tribal affairs. So at the end of August, HRSA established the Office of Intergovernmental and External Affairs, or HRSA IEA, and it serves as the principal lead agency on intergovernmental and external affairs, regional operations, and tribal partnerships. HRSA IEA includes an Office of Tribal Affairs, which will continue to manage the HRSA Tribal Advisory Committee, the Council, and participate in tribal consultations and collaborate with IHS and other federal and community stakeholders. And this new structure also fosters greater collaboration among the tribal work that we do across HRSA and support on the ground through our regional offices. HRSA IEA is led by Natasha Caloris, who you met earlier. The Tribal Affairs Manager is Captain Skip Clellan, a citizen of the Cheyenne and Arapaho tribes, who has worked with many of you during his time at CDC. Skip is not here with us today, but has already been a tremendous asset to me, to Natasha, as we stand up the TAC and then do the other things that we have planned to improve and expand our relationship. You can see our new org chart on our website at hrsa.gov. But hopefully, as Natasha mentioned, this will allow us to leverage the many activities that we have happening, in communities through our regional offices with our headquarters and program work. Turning now to HRSA's budget, I'm pleased to report that funding opportunities and awards to tribes and tribal organizations have increased consistently in recent years. In fiscal year 2020, tribes were eligible for 75 HRSA grant opportunities and received 237 awards totaling nearly $152 million to support tribal health services. And as we increase our funding, we also want to address issues that you have brought to our attention, such as the Uniform Data System, also referred to as UDS, and Health Professions Shortage Area, or HRSA scoring. Later today, Dr. Janelle McCludden will discuss annual updates on shortage designation scoring, and Alec Sripipatana and Judith Van Alstyne will update you on our efforts with the UDS. We've also heard many tribal leaders express an interest in learning more about access to broadband services and telehealth services. And as a federal leader in bringing telehealth to rural and tribal populations, HRSA recognizes the many benefits and increased access to care that the technology brings to your communities. And in fact, another aspect of our reorganization was to elevate our Office for the Advancement of Telehealth from the Federal Office of Rural Health Policy to the HRSA level because of and in recognition of the just much broader role that we have been playing over the last several years, working with the department and even across the government on telehealth issues. Last month, HRSA's Office for the Advancement of Telehealth gathered a set of experts from across HHS agencies, the Federal Communications Commission, the U.S. Department of Agriculture, the Department of Commerce's National Telecommunications Administration to share the federal resources available for telehealth and broadband services with tribal leaders. And we held this session partnering with HRSA in response to requests that we received from tribal leaders. And we plan to hold similar sessions in the future and really just appreciate your feedback. But again, kind of want to demonstrate to you all that if we have resources that we can bring to help you all understand how to connect federal programs or any other way that we can support the work that you do, we are willing to do that. Another topic that I know is of great interest to the audience is HRSA's Tribal Advisory Council, or TAC. Since we last reported to you, we have made progress in establishing the TAC. So far we have filled 10 of the 12 available delegate positions, and we continue to recruit for the Phoenix and Tucson areas. We hope to be providing that initial orientation for delegates in the coming weeks and are preparing for the first HRSA Tribal Advisory Council meeting this December. So in closing, I just want to reaffirm HRSA's desire to strengthen, continually work to strengthen our relationship. Your ideas, suggestions, and feedback are critical to our ongoing and mutual efforts to ensure that American Indian and Alaskan Natives have ready access to quality healthcare and services. I want to thank you for your continued support as we move forward. I also just wanted to take an opportunity to thank Michelle and Elijah. I kind of combined your names somehow, just for their support of tribal work over the last several years, and for their helping us transition as we have this first meeting as we transition to our new structure. Just really appreciate your support and guidance through the years. With that, I will turn it back over to Chairman Larry Wright. Thank you.
Thank you so much for those updates and that important information. Now we will start the discussion portion of the meeting. Like other listeners. Yes.
I think we have a couple more presentations first.
I'm sorry.
I'm sorry for interrupting. I think we have the modernization update next.
Yes, thank you. Scrolled down too far. We have next we have Janelle McCutcheon, shortage chief of the shortage designation branch.
Good morning, everyone. We're still in the morning. So good morning and good afternoon to those of you that are on the West Coast or in the the Midwest. I want to start by saying thank you for giving us the opportunity to present on the National Shortage Designation update that occurred on September 14th and was processed in the system. My name is Dr. Janelle McCutcheon. I feel like I've spoken to most of you over the course of the last 4 years on our shortage designation modernization project. And today I'm going to aim to bring that full circle and kind of bring you up to speed on where we are to date with the shortage designation modernization project. I see my slides have disappeared. I can share my screen if that's okay.
There we go.
There we go. All right. No problem. Next slide, please. So really what I'm going to be focusing on today is giving you guys an overview of the health professional shortage areas for those that are not familiar or have not heard about it. Give you a little bit of a refresher on specifically what they are, how they are used, and why it is relevant to the tribal community. And next, I'm going to talk about the National Shortage Designation Update, what that process entailed, when it was completed, and how it directly affects you again. And then I'm going to close out by talking about the resources that are available to you, specifically surrounding the use of the shortage designations and how they apply and would be beneficial for continual involvement for your communities. Next slide, please. Before I jump into the breadth of the presentation, I do want to thank the individuals listed here and say that I am looking forward to working with those members of the HRSA TAC in our ongoing shortest designation modernization project. Your advice and recommendations to date have been extremely valuable in aiding us in getting to where we are now with this project that we begun in 2013. And it has been integral in the success of moving the needle forward and modernizing our regulatory processes surrounding the shortest designation process. Next slide, please. For those of you that are not familiar, shortest designations, the long and the short of it, if you remember nothing else, are designed to help target resources. They were originally created for the purposes of placing National Health Service Corps participants in the areas of highest need. But since then, a lot of programs have definitely hitched their wagons to our horses, for lack of a better term. And I've got a couple of the federal programs listed here on the slide to just show you which programs use our health professional shortage areas for the purposes of allocating resources. But let you know that this list is not extensive. As I mentioned, this is some of the programs that use them. And again, just as a reminder that this was originally, or the HRSA process and the scoring of those HRSAs, the numbers that come out of those, were originally created for the processes of the National Health Service Corps and just ensuring that we were putting our participants in the areas of highest need. Next slide, please. So why this is relevant to tribal entities or to tribal countries. So you qualify for a health professional shortage area designation automatically by virtue of being a tribally run clinic, an urban Indian organization, a dual funded tribal health center, and or federally run Indian Health Service clinic. So just automatically by virtue of qualifying under any of those federal identifiers, you get a HRSA score. Or you qualify as a HRSA, which allows you to enter into what is now called the automatic HRSA portal and gets you a score generated. As I mentioned earlier in the call, and I heard that Ms. Espinosa mentioned it also, we completed a national shortage designation update on September 14th of 2021 of all the designations within the system, including those that were automatically designated. And what that means is we updated your score using the standardized data within the system and the information you previously provided us within the portal specific to your tribal entity or your tribal clinic. Next slide, please. As a result of that update, these are the ITUs, what we call them, but Indian Tribal and Urban Indian Organization results that we had from the update completed on September 14th. Of the 2,463 ITUs that were replaced, 62% of them had no change in score. That means even with the standardized data and any information that they added within that time frame, they had no change in their score at all. 26% had a score change of 2 points up or less. And then of course, 11% had a score change of 3 points or more. So you can see that divvied out here in this histogram that kind of shows you that about 1,500 plus had no change in score at all. And then going one way or the other, we had more entities getting increase in scores than any of those that lost them. Next slide, please. Why are these scores relevant, or how are these scores used for the purposes of placement for the National Health Service Corps clinician? These scores are generally used, all-encompassing, for lack of a better term, to place NTHC participants, which I did say earlier, but specific to tribal entities. Dr. Padilla, who is the associate administrator of the Bureau of Health Workforce, has worked tirelessly to ensure that we continue to get this $15 million set aside for Indian tribal and urban Indian sites who get applicants to the National Health Service Corps. So automatically, if an individual applies for the National Health Service Corps for a new loan repayment contract at an Indian tribal or urban Indian health clinic, they get awarded out of this $15 million set aside. We have had this set aside for the last 2 fiscal years. We're hoping to see it again in fiscal year 2022 at this point. And with these funds, we have been able to award every single applicant at an ITU over the last 3 fiscal years. So in fiscal year 19, 20, and 2020 and 21, we were able to award every NHSC applicant who applied to serve their term at an Indian tribal and urban Indian health facility, which means for these last 3 fiscal years, scores have not been a factor in getting placement at ITUs or getting NHSC participants at ITUs. The set aside, again, has resulted in us being able to award everyone in those last 3 years. We anticipate being able to do that again this year, and continuously encourage you guys to communicate to your clinicians working at your facility that if they are interested in applying at the National Health Service Corps or for the National Health Service Corps, regardless of what those scores are, even if you have a 2, that they should definitely submit their application. I can confirm that last year's fiscal year 2020, we awarded specifically at Indian Tribal and Urban Indian Health Clinics all the way down to a score of 5. We got participants into the National Health Service Corps serving at tribal clinics with a score of 5, simply because they applied. So please, please, please continue to encourage those who are working at your clinics and at your sites to definitely apply for the National Health Service Corps, regardless of what HRSA score they have, by virtue, again, of being an Indian, tribal, or urban Indian facility. You automatically get designated. Your scores currently are not a concern, as we have a $15 million set aside to award individuals who are applying to work at tribal facilities automatically. What I do want to say concerning the update is the current individuals who are working again for NHSC purposes are not impacted in any way, shape, or form. They can continue to work or continue to complete their service obligations, even if their score has changed. So they're not going to have to mention that or have to worry about that. And they are eligible to continue to submit continuation applications, because we award those first, regardless of any score fluctuations in the future. And again, by virtue of being an ITU or an Indian Tribal and Urban Indian Health Clinic, you're automatically designated, so they never have to worry about losing that designation. They can continue to provide services at your facility and apply for the National Health Service Corps continuations as long as they have eligible loans. Next slide, please. The one thing that I want to say before I jump into the ability to get your facility-specific data into the system is that our field strength for the National Health Service Corps at ITUs has increased drastically over the course of the last 4 years. And we would like to credit not only the hard work that the Division of National Health Service Corps has been doing, but also the $50 million set aside, and that we've gone from having about 430 participants at NHSC sites to currently having 1,023 participants at NHSC sites, which is our highest field strength that we've had at ITUs in history. And again, this is largely because of that $50 million set aside, wanting to again reiterate that you please encourage your clinicians who are interested in participating in the NHSC to definitely apply regardless of what their current score is. That we really want to see this number continue to grow. And again, to remind you that once they are in, as long as they continue to have qualifying loans and are meeting all programmatic requirements, they can continue to apply for a continuation. So that's the NHSC piece. Now I want to talk a little bit about the portal. As part of the shortest designation modernization process, we created an auto HRSA or automatically designated HRSA portal, which allows facilities to see their score at any point in time. It's accessible 24/7 unless we're doing an update, in which we do communicate to our points of contact that the system's going to be down for a couple of hours. But within that auto HRSA portal, you have the ability to submit this site-specific or tribe-specific information. You can submit the number of patients that you have per zip code, regardless of where that zip code is. If you, for example, if you are, and I think I've shared this example with Skip before, but if you are a member of the Ponca tribe in Nebraska and you happen to have some individuals living out in Connecticut that do fly all the way back to Nebraska to get care, you can submit the zip codes where these individuals live in Connecticut into the system, since they are a part of your patient population. You can also provide us with the percent of patients with known income at or below 100% FPL, the ages of your patients, and then of course, the fluoridated water access, and then the misuse of alcohol and substance rates for the worst quartile in the nation, region, or state. So that's information that you can submit yourself as long as you are a approved site point of contact within the portal at any point in time to request a rescore based on the new data that you have available. I included the link that gets you to the webinars, specifically to how to process the system. But if the webinars are an issue and you would rather have an interface directly with someone or have someone walk through the process with you, you can definitely email us at sdmp@hrsa.gov. And we are more than willing to set up one-on-one TA sessions with you to explain the process, walk you through how to submit that information and what that would look like in the portal to get your score updated. Next slide, please. Last thing, if you don't remember anything else that I said today, I do want to again say thank you to those that have assisted us in the process of this shortage designation modernization project to date. I want to reiterate our excitement to work with the members of the HRSA TAC moving forward on the things that we have coming down the pike. Let you guys know again that we did that national shortage designation update on the 14th of September. It is completed, those scores are live. You can see them in our HRSA data warehouse at this time or in the Auto HPSA portal if you have access to your site-specific account. I want to remind you that current participants and those that were awarded in fiscal year 2021 are not impacted by the score. But again, also reiterate that because of that $15 million set aside, we do or have had the opportunity and the ability to award all applicants who have submitted applications at tribal entities or tribal clinics. Continue to encourage you to reach out to them to tell them to definitely apply. We are hoping to see that $50 million set aside again in our next fiscal budget and wanting to definitely ensure that we are using that to the fullest ability and continue to grow our field string. Tribes have the flexibility to, again, use their facility-specific data to be rescored at any time via that portal. That portal is up unless we're doing updates, and we let you know when we're doing those. And again, I included the email address here to reach out to my team directly to set up any briefings or technical assistance requests if you want to have a more ideal process on how, or have a one-on-one session on how to get into the portal and submit your information on your own. We are committed to making sure we continue to partner with you and assist you throughout this entire process and as we continue to modernize shortage designations. That is all I have, Mr. Wright. I don't know if this is the time that we open up for questions or exactly how that's scheduled to process out to be, but if you don't remember anything else, sdmp@hrsa.gov to reach out to me and my team, and we would definitely assist you throughout this process. Thank you, Mr. Wright.
Thank you, Ms. McCutcheon. And we'll follow up with questions here after our other presentations. And so with that, we'll turn next to the Bureau of Primary Healthcare. And next, and I apologize, Doctor, if I get your name wrong, but we have Alec Siripatana, Director of Data and Evaluation Division.
And it was perfect. Thank you, Mr. Wright. It's always like the first day of class where you get that long pause where the teacher goes to the roll, and when they stop around the S's, I know it's probably me. I'm actually going to invite Judy Van Alstyne to join me, and she will talk us through some of our updates around the uniform data system.
Thank you, Alec, and thank you, Chairman. As mentioned, my name is Judy Van Alstyne, and I work with our team in HRSA's Bureau of Primary Healthcare, where I lead the production of our uniform data system, better known as UDS. I'm really glad to be with you all for this important consultation. Before I get started, just want to take a minute. We know that the pandemic has had tremendous impact really on every aspect of life. And I want to just acknowledge the work of our health centers, partners, as well as health professionals in support of the communities across the regions and the most impacted by COVID. Next slide, please. The Uniform Data System is a standardized reporting system capturing performance measures, including patient characteristics, staffing, clinical services, clinical quality measures, and financial data from nearly 1,400 health centers, serving nearly 29 million patients with more than 255,000 FTEs as part of HRSA's Health Center program. At their foundation, health centers provide patient-centered, comprehensive, integrated care through a variety of services. Each year, Health Center program awardees and those with lookalike designation are required to report on the measures defined in the UDS as a primary source of health center program performance data. These data support efforts to further expand access to care, address health disparities, improve quality of care, as well as reduce costs. Next slide, please. On this slide, and as an example, you will see a sample of UDS measures, specifically some of our clinical quality measures and their performance in 2019 and 2020. Pursuant to the Paperwork Reduction Act, or PRA, which gives the United States Office of Management and Budget authority over the collection of certain information, including the measures that comprise the tables in the Uniform Data System instrument, the UDS is reviewed and approved on a 3-year OMB cycle or cadence. Outside of that 3-year cycle, we try our best not to make substantial changes to UDS measures, such as those exemplified on this slide. This is with particular attention to not adding additional reporting burden for health centers and maintaining consistency and comparability of data year over year for the nearly 1,400 health centers reporting. And for 2020, that was 1,375 health centers to be exact. The next substantial OMB review is slated to be in support of what will be our 2023 UDS instrument for UDS reports due from health centers in February of 2024. Of the 1,375 health centers who reported 2020 UDS, 33 of those centers are funded as part of HRSA's Health Center program, administered through our Bureau of Primary Health Care and through the Indian Health Service. In this context, we refer to these health centers as duly funded. Next slide, please. Another topic of interest to this convening revolves around the primary care workforce and the placement and labeling of community health aid program participants in UDS, including community health aid practitioners or those who have achieved the 5th level and practicing under the supervision of a licensed clinician, physician, or physician's assistant. The community health aid program and the individuals pursuing such training requirements are an important allied health group of professionals and incredibly important to the primary care landscape and delivery in tribal and rural communities, such as those in Alaska, where we know the program was created and modeled. Based on what we know about CHAP's training and credentials, we continue to include this group of health professionals within Table 5 of the UDS, labeled as Staffing and Utilization Table, on line 22, which we label as Other Professional Services. Of note, this line does allow health centers within the UDS report submission environment to specify or write in the role of the FTEs they are reporting on this line, be it a physical therapist, dietitian, community health aid practitioner, podiatrist, or other health professional categories. In our reporting requirements document, which we call the UDS manual, we specifically note that CHAPs are to be counted as part of this line. From our latest available, which would be our UDS 2020 data, the data output side as opposed to the data governance side, which I've been talking through, the duly funded, again, HRSA and IHS health centers are serving close to 154,000 patients with about 3,790 FTEs and about 337 FTEs reported on that other services line, again, line 22 of UDS Table 5, the line inclusive of community health aid practitioners. Of those 33 duly funded centers, all of which, 14 of which are in Alaska and all have rural designation, are serving close to 60,000 patients through almost 2,044 FTEs, of which 314 FTEs were reported on Table 5, line 22, again, the line inclusive of CHAPs. So that would be 314 reported altogether. And of course, not all of those are CHAPs, inclusive of other professional service roles. Next slide, please. Across the primary healthcare landscape, there is certainly emphasis on reporting burden reduction, interoperability of systems, and meaningful use of electronic data. As such, historically and at present for 2021 UDS reporting, the reporting cycle we are currently in the throes of, HRSA works with IHS, our sister agency within the U.S. Department of Health and Human Services, to provide technical assistance through transfer of funds to IHS through an interagency agreement to translate RPMS, or the Resource and Patient Management System, data elements for the purpose of UDS reporting in support of the 33 duly funded health centers. Anecdotally, we have heard that there has been a shift away from the IHS-supported RPMS towards commercial EHR vendors and products among duly funded health centers. We also could see from our 2021 UDS data that there were 7 EHR vendors reported with close to 20 EHR vendor products being used among duly funded health centers. Now, with that all being said, RPMS was still the most frequently reported system being used. For UDS, we offer many touch points for technical assistance to all health centers and have included a variety of links to key web pages and resources on this slide. Our UDS resources page is really the gateway to our suite of UDS training and technical assistance resources, with technical materials and recordings of UDS-TA webinars, FAQs, as well as other resource materials to support health centers with many of the most common UDS reporting requirement questions. I also would like to note that each year we partner with state and territory primary care associations to host state or region-based UDS trainings, which is a great opportunity for health centers to get insights and answers about UDS reporting requirements that may have some unique impacts on their particular jurisdiction. The schedule of these training opportunities, along with contact information to secure spots for the trainings, can be found on our UDS resources page under the 2021 UDS resource tab dropdown. These trainings start up in October and really go through December, grouped by region and then within region by state. So some great information there. With that information in tow, I would like to turn the mic back over to Chairman. Thank you.
Thank you. Thank you so much again for those updates and that important information. Now we will start the discussion portion of the meeting. Like other listening sessions, we will follow tribal protocol and invite our elected tribal leaders to make comments, share recommendations, and ask questions first. Once our tribal leaders have had a chance to speak, we will open the floor to other members of our audience. We'll start off, we have one of our NIHB board of directors to start us off with a question first. And with that, I would like to invite my fellow moderator, Melissa Gower, to ask a question. Melissa.
Thank you, Chairman Wright. Thank you to all of HRSA's presenters. I'd like to address HRSA's role in helping us with our provider shortages in our facilities. I'm sure that, as you know and probably have heard already in many different settings, that we Indian healthcare facilities, as well as all healthcare facilities these days, are seeing a dramatic shortage of providers due to the surge of the COVID Delta variant. We were already experiencing a serious provider shortage, which has been made worse by the COVID-19 pandemic, creating burnout in providers. But the number of rising COVID cases has now stretched the ITU systems to crisis standards of care. With high cases, not only are there not enough providers, but our remaining providers are experiencing more severe burnout, and our providers with children are having to miss work when their children must isolate due to COVID exposures in school. With that said, I have 3 asks or requests for the agency that we would like for you to consider. First, HRSA must begin working now to address these shortages and provider burnout as the public health emergency continues to impact our provider levels. Secondly, we ask that HRSA continue its support for the National Health Service Corps placements within the ITU facilities and work to expand the reach of that program into Indian country. And finally, assist tribes and IHS in addressing provider shortages. We request HRSA to develop a tribal set aside within the Teaching Health Center's graduate medical education program for tribal and IHS medical residency programs. More and more tribes are wanting to start tribal medical residency programs in their healthcare systems to assist in provider shortages, because we know that when we provide the training in our settings, that those providers a lot of time will stay in that facility after they graduate from residency. But without critical funding, it's almost impossible for tribal healthcare facilities to start residency programs. This would make a really big impact in Indian country. It has been an ask for a few years now, and because of the big impact in Indian country that it would make, I truly hope HRSA will consider this request soon. Thank you, Chairman Wright.
Thank you. And turn it over to members of HRSA to respond.
I wanted to start off by thanking you for raising that very important issue. I mean, you know, I think we all know that the health workforce was strained before the pandemic, and it's been significantly exacerbated. I did want to turn it over to Dr. Luis Padilla, who leads our Bureau of Health Workforce, because some of the areas, actually each of the areas that you mentioned, there are some additional resources that were provided through the American Rescue Plan. Obviously, the issues you raised, they're worth a whole discussion, many discussions. Maybe Luis, if you could give just a summary of some of the new investments that we have in those areas. Are you, Luis?
Okay. Hi, Diana, hopefully you could, I had a transition over to the panel. Thank you for that. And it's a pleasure to be with you, and thank you for allowing me the opportunity to address this issue. And we fully understand, as Dr. McCutcheon articulated, the needs in tribal Indian country. And as Diana mentioned, and as you relayed, there is a need to address provider resiliency and burnout among all healthcare professionals, particularly those in tribal Indian country, who are addressing underserved needs in those communities. We've released funding in the amount of $103 million to address provider resiliency. We received over 430 applications across those 3 funding opportunities. So it demonstrates a great need in this area. We'll be putting those awards out as quickly as possible and looking for opportunities to further strengthen that in Indian tribal country. Right now, I can't tell you whether or not ITU or IHS sites or tribal organizations applied for these fundings, but we're going to get that information and hopefully transmit that to you. So that's one part, I think, of your question. The other was around the Teaching Health Center GME program. We're pleased to share that as part of the ARP funding that we received, we did put out a funding notice for development grants in this area around THC GME programs. That was $25 million to support 50 awards to start the process of developing residency programs across the country and these communities. We received over 60 applications. We're looking now to fund 55 of those awards. And again, as we begin to look at those applications that came in, sharing with you how many tribal organizations came in for that funding. We did also release and close now the application to have an expansion of the THC GME program for new programs, also as a part of the $330 million that we received as part of the ARP appropriations. So what we're seeing here is an overall expansion of the program. And certainly prior to the funding, we had a number of tribal entities that had come in for that funding that are current awardees, and we're hoping to see an expansion of that. Tribal entities are eligible for that funding opportunity. We believe, because of the focus of the program being heavily on community-based training of primary care providers, that we believe tribal entities would be very competitive for this. And I encourage your support in the outreach, not only of the last one, obviously those have closed, but we're hopeful that Congress will appropriate additional money to further expand this. And as we do, we would look to our partners, our tribal partners, to get the word out about the outreach to come in for this funding. I don't know if there's any other questions on those 2 programs in particular.
She also raised the National Health Service Corps placements.
Yes.
Yeah,
thank you.
I think that's another area where, we need to maybe strengthen our technical assistance to get more folks applying and updating their profiles so that they.
Sure. Yeah, and so we've been doing that for a number of years, and I'm happy to report that as of September 30th, we have 988 sites that have joined the National Service Corps and are now actively on our what we call our Health Workforce Connector, where applicants can see those sites. This has been a concerted effort on the part of our Division of Regional Operations to go out individually to the tribal entities to support their efforts in developing these profiles. So over the last few years, what we've seen is a doubling of those sites through our efforts to come in for that portal to develop profiles and to encourage applicants from those sites to come in. I do want to stress again what Dr. McCutcheon mentioned. What we saw during this last cycle, despite the additional money that we have and the set aside, was applications coming in from a HRSA 5. That meant that if there are clinicians below those HRSAs, they didn't come in for these awards where we could have awarded them. So again, our ask is that we continue to work together on this outreach to encourage those clinicians at these sites to come in for these applications, because certainly we have the ability to go further down that HRSA list with our current level of funding.
Well, thank you for that response, and thank you, Melissa, for those questions. I would like to now invite elected tribal leaders in the audience to ask questions and share their comments or provide recommendations first. If you would like to speak, please put your name in the chat box and the NIHB staff will unmute you and you can ask your question directly to our speakers. We ask that you please start by sharing your name, title, and tribe. Also, if you are a HRSA TAC member, please note that in your introduction. Once you are unmuted, we also invite you to turn your camera on if you would like, so that we can see you and ask as you ask your question. I know first we have Chairman Dr. Aaron Payment, the first tribal elected leader. Like to ask a question.
Ani, can you hear me?
We can.
All right, so I'm Chairperson Aaron Payment of the Sault Ste. Marie Tribe. I also serve on the HHS staff, first vice president for NCAI. And I'm glad to see my colleague, Chairman Wright, will be a fellow HRSA TAC member. So we'll be able to work on that space as well, Larry. So National Health Service Corps placements are largely determined by health professional shortage areas, or HRSAs, for medical, behavioral, and dental care accessibility. We're concerned that the HRSA scoring process, while we appreciate that Indian health providers are auto HRSAs, we don't believe that the current scoring methodology accurately reflects the poverty level many tribes experience or the urgent need we have for providers. It's also important to note that the U.S. Census data is an unreliable data set for Indian country. At 2 p.m. today, I'll be moderating a session at NCAI on what the new census tells us. And while there are improvements, there remain great disparities across states and regions surrounding tribal territories. Despite documented unreliability, HRSA currently uses census data to calculate population poverty scores that do not accurately reflect native populations. Because of the extreme need in Indian country, we strongly urge and recommend that our providers should receive the highest possible HRSA scores to reflect our high level of need. Additionally, when national data is not available, HRSA should default to a maximum HRSA score for tribal and urban programs. Missing data accounts for 0 scores in the areas where Indian country has the highest health disparities, including infant health and substance abuse. Zeroing out HRSA scores in highest need areas due to lack of data is just not good science or good public policy. Next, we request that HRSA work with IHS to create a unique HRSA scoring system that is reflective of the unique needs in Indian country. I also ask that HRSA engage in true consultation on the recalibration of the HRSA scoring criteria. This current consultation is not sufficient to gain the diverse tribal input needed to truly understand the needs of Indian country. HRSA should engage with the new HRSA TAC and conduct a robust tribal consultation in all regions to understand the true need in Indian country and commit to working collaboratively with tribal nations to identify ways to address those needs. An even better solution is to rededicate an AmeriCorps or Peace Corps type approach to affirmatively address the worst of the worst statistics in the Broken Promise report for a duration of times to catch us up to the rest of the country. The treaty and trust obligation for health and the health education and social welfare would necessitate this. And so finally, while Dr. if I can say it right, Dr. McCutcheon may have already addressed this. I do have a specific question that I was asked to pose, and that's how many IHS tribal and urban facilities are submitting facility-specific supplemental data to be rescored? And of those, how many are rescored?
Thank you, Chairman Payment, for your comments, and I'm looking forward to having you on the TAC. I see you're ready to go. I think I would suspect that those might be data that Janelle or Melissa might need a little time, unless you have them on your fingertips too, that we might have to follow up. Is that right, Janelle?
So what I don't have is post the NSDU who has submitted a facility-specific or supplemental data rescore. I don't have those numbers on hand. I have already submitted. Chairman Payment was kind enough to send his question in the chat. So I've already sent that forward to our team for them to start looking at that number. But what I do want to say is every individual that submits supplemental data and sends in a rescore request gets rescored. The system is designed purposefully to ensure that you have the ability to submit your information. At no point in time is that being wiped out. The minute you're submitting your information to us, which does include the ability to submit to one of the points that you made, percent of patients with known income at or below 100% FPL, specific to your tribe. So if you have the data that's specific to your tribe, completely separate from census, because we recognize that census data is not always indicative of what's happening in Indian country, you have the ability to submit that information as part of that supplemental data rescore. And the minute you submit it, as long as you upload the justification documentation, the system processes it. There's no cancellation of that rescore request. And once that rescore request is processed, we can't go back to your previous score. So that's one of the things that I like to make sure is very, very clear. The minute you submit that information, the system is under the impression, rightfully so, that you're submitting the most up-to-date information and processing your rescore based on that data. So again, I don't have the numbers of how many individuals or how many facilities have requested supplemental data rescores after the NSDU or the National Shortest Designation update, but I can say affirmatively that once a rescore request, a supplemental data rescore is processed, it is automatically processed all the way through. At no point in time are those canceled. There's another point that you raised, that scores are being zeroed out. With the creation of this auto HRSA portal, that is no longer a part of the process. The system is designed to provide you with the score based on the information that is there. One of the things that was mentioned was transportation issues or the identification specifically of the nearest source of care. I don't know how familiar everyone is with the terminology surrounding HRSAs, but that's looking at how far an individual has to travel to get to care outside of their spatial area. If a provider is not identified as providing care to Indian country, specifically to your tribe, the system would automatically give you the 5 points. It does not zero it out in the other direction. So if there's not someone available within the 30 to 40 minute travel time or distance that we've identified, you get the 5 points. We do not zero out scores. That's one of the big things that we definitely wanted to have as a driving factor in the development of the auto HRSA process. And then also, again, the ability for you to provide tribe-specific data into our system, because we recognize that census doesn't always have the best information as it relates to what's happening in tribal country. I will, once I get that data from the team regarding how many facility-specific or supplemental data rescores have been requested, I will make sure that that information gets to Ms. Cloris and Michelle Adler so they can share it with those who are on the call.
And the Chair Payment also raised the issue of the scoring methodology, which I think we all agree doesn't function the way that it needs to. And I think that is a very critical topic for the TAC and also for consultations, as you said, because obviously, you know, we've only two have had the opportunity to speak, and both have raised workforce issues. We know how critically important workforce is to tribes. Janelle or one of the other BHW colleagues, can you just give just a brief update? Because we did put out an RFI and just kind of where we are in that process, just so everyone has the context of like what we have done so far to initiate a process to update the scoring methodology.
Definitely. As part of the shortage designation modernization project and with Ms. Espinosa's support, which I am really excited about, we put out a request for information last year, asking stakeholders to provide us with input on how they would like the scores to be modernized or modified, of course, within the parameters of the statute and keeping in line with what we could do, things that we could change, data sources that we can add in. We got over, I believe, 250 comments. Specifically, I've got here, we got 7 comments from Indian country. We have processed and analyzed and evaluated all the data sources that were presented and shared with us, and did some additional research on our own to identify what other things were available nationwide to be able to make those modifications. And I feel like we're in the final phases of being able to develop something that we could publish within a federal registry notice for additional comment or proposed criteria changes for additional comment here, possibly in the next 4 to 6 months. Of course, running those by Dr. Padilla and Ms. Espinosa prior to them coming to you. But you would find no one on my team who would agree or who would believe or say that the way the current scoring methodology is appropriate to the way medicine is practiced in the 21st century. We have been working diligently to ensure that within the parameters of law and the abilities that we have, we're making modifications that will be beneficial, definitely for Indian country and the nation as a whole.
So great timing to really start focusing on this issue. And then just one additional point, just for awareness, maybe you could mention, the maternity care target areas, because that is a new feature. And I don't know if you or Dr. Padilla wants to just kind of mention that new authority and kind of where we are with that, because I'm sure that Indian country also has significant needs for maternity care. That is a challenge across particularly rural areas.
Definitely. Thank you for that, Mrs. Espinosa. So in 2019, one of the authorities that we received was for the establishment of maternity care target areas, and I think Melissa's jumping on here. The establishment of maternity care target areas in existing primary care designations. So with that, we were charged, or BHW specifically was charged with developing a criteria for how we could identify a score or a ranking for these areas. So on September 26th, we published a federal registry notice detailing the criteria that we developed based on the information, again, that we received from stakeholders. We also published a request for information last year, got a lot of feedback from stakeholders and subject matter experts in the field of maternity care, spoke to the Maternal Health Child Bureau, ACFS, lots of different organizations and associations, but definitely got feedback from, I believe, 4 tribal entities to that RFI specifically, and have since then developed that MICTA criteria, maternity care target area criteria, and published it for comment. It would be open for comment until November 26th. I would ensure that that link is provided to Ms. Allender and Ms. Clara, so you guys have access to it and have the ability to provide us with comments. And then once the HRSA tag formally gets established, also give you guys the ability to discuss that in that setting. I see Melissa's on, so I'm going to pass it on to her if she wants to say anything in addition.
Yeah, thanks, Janelle. So the only thing I would add to what Janelle said is that the Increasing Access to Maternity Care Act, what it did in creating the maternity care target areas is it has essentially specified that once we implement them in the maternity care target areas, we will need to use those as opposed to HRSAs for distributing National Health Service Corps providers who provide maternity care instead of the regular primary care HRSA. So that's going to be the end result. However, as Dr. McCutcheon and I believe Dr. Padilla have been communicating right now, with the $15 million set aside that we've had for the last 3 years in the National Health Service Corps for providers serving at ITU sites, the tribal and IHS and urban Indian sites, that we have actually awarded every applicant for the NTHC loan repayment programs who serves at an ITU or an ITU site, who's been eligible for the program. So at least at this point in time, while we are continuing to refine our HRSAs and work on the HRSAs to improve accuracy of the data, the funding exists to, at least at this point in time, has been there to award everybody from tribal sites who applies to the program. So we certainly take it seriously and are continuing our work on the data. But and you know, those maternity care target areas will be implemented and will start being the way we prioritize the awards for maternity care providers at ITUs. But you know, at least at this point, we are still in that position where we, you know, are funding everyone who's applying. So.
Well, thank you for those responses. Thank you, Chairperson Payment, for the question. Next in our queue, we have Councilman Nate Tyler for elected leaders. Mr. Tyler.
All right, I appreciate that. Can you hear me, Chairman?
Yes.
Okay, thanks a lot. Nate Tyler, Makah Tribal Council, Washington State. Speaking on behalf of the 43 federally recognized tribes out of the Portland area Indian Health Board. I think I have a number of issues I want to bring up. I think 3 or 4 issues. And I think it's important to note the first 2 issues are pretty important. Consultation, the tribal consultation process. It's an important communication tool for an open exchange between us. Is between senior leadership. So I'd like to recommend on behalf of the Portland area, in order to improve the annual tribal consultation process, that we request that you allow tribes and tribal organizations to submit written testimonies at least 30 days after the annual tribal consultation concludes. And then the second issue is the HRSA Tribal Advisory Committee. As we move our tribal communities forward in recovery from the COVID-19 pandemic, healthcare delivery will never be the same. TACs play a vital role in advising and informing federal agencies on the impact that federal policy has on Indian healthcare systems. So I'd like to recommend that we request that you immediately schedule the first HRSA TAC meeting and provide notice to tribes and tribal organizations. We also recommend that the TAC meets at least biannually with monthly conference calls throughout the year. We also recommend that HRSA uses the TAC to develop effective tribal consultation policies and utilize those policies to engage with tribes in meaningful consultation. We also urge HRSA to use the TAC to set the agenda for consultations, you know, and working together at the highest level. Prf Funding Concerns. Recently, HRSA announced a 60-day grace period for provider relief funds, reporting period 1 for reporting that is due September 30th, 2021. We are seeing a recent uptick in COVID-19 cases and hospitalizations across the Portland area. Idaho has moved into crisis standards of care across the entire state. Their patients are being transferred to Washington, Montana, Utah, and Nevada. In Washington, our hospital beds are at or reaching capacity. And here at Makah, we have 2 hospitals close by, and they're smaller scale. And on a number of occasions, they've been maxed out. So, and that's just in this last month. Our healthcare providers are overwhelmed with the increased cases and the recent rollout of the boosters. We need all resources necessary with the maximum flexibility to use those resources. We request that healthcare providers are allowed to expend all provider relief funds by at least September 30th, 2022, or at the end of the public health emergency, whichever is later. The HRSA scoring, the new health professional shortage area scoring methodology creates additional barriers to the many challenges we have filling vacancies. The Portland area recommends the following changes to the scoring. ITU clinics should be given a score of 10 for all ratio calculations measuring the available providers to the given population, because the general provider population is not equipped to provide holistic, culturally competent care for our people, to our people. ITU clinics should be given a score of 5 for all travel time to nearest source of care calculations, because the general provider population is not equipped to provide holistic, culturally competent care to our people. Engage the HRSA Advisory Committee in reviewing comments and developing modifications to the scoring methodology. Public health scholarships. Many of the Portland area tribes are experiencing longstanding medical and behavioral health provider shortages and recruitment and retention issues. This is even more exacerbated for those tribes in rural areas and the COVID-19 pandemic. Our healthcare providers are facing burnout, and we are finding it even more difficult to compete with local healthcare providers, wage scales, and benefits. Indian country needs critical investments from the federal government to educate, recruit, and expand its pool of qualified medical and healthcare administration professionals. In order to accomplish this, we need at least 90 million in public health scholarships within HRSA for Indian country and tribal health providers. So just on behalf of the Portland area, I appreciate this opportunity to take part in the consultation. And I look forward to working with you guys in the future. So appreciate it. Thanks a lot. Thanks, Chairman.
Thank you, Councilman.
Excuse me. Thank you, Councilman Tyler, for your recommendations. I think on the first points, as far as, you know, how we communicate and how we do our consultation, I do think that was one of the key things that I thought our TAC should help us enhance and do better and have those conversations. We also, I believe, you know, saw some written questions submitted in advance where folks were also making recommendations about when we should use Dear Tribal Leader letters, for example. So I think our TAC will be a great forum for us to have those conversations on what are the most respectful and appropriate ways for us to be communicating with you all to make sure you get the information that you need. So I appreciate that. On one specific question that you asked, I don't see any reason, so Elijah or Michelle, why we cannot continue to take testimony for 30 days after this meeting. I think, unless there's some barrier that I don't know if our tribal consultation policy is even that specific, but I don't have any problem doing that. And I think it's a valid point. People need time to hear things and digest and think about them. And I appreciate the substantive, meaningful comments that you all provide. And I know that requires effort on your part. So any obstacles to that you see, Michelle or Elijah?
Hi, Diane. This is Elijah. I do not see any obstacles at all. And I think that would be in order to inform Indian country, as you have, that we will accept testimonies at least 30 days after the commence of our meeting today.
Okay, so we will make sure, we will follow up and make sure everyone's aware of that. But thank you for that suggestion. I think you also had many suggestions about the HRSA scoring. You know, we know that that's an issue as we were discussing earlier, and I think that it's one that deserves its own discussion. So we'll figure out whether we start that with the TAC. You know, as I think both you and Chair Payment have mentioned, it's probably a combination of TAC and consultation for the HRSA stuff. on the provider relief fund, I hear your concerns. I know that you all have made those requests. We have raised the concerns and continue to work through them. I know we have folks from our provider relief fund on the line, and I just wonder if, for the benefit of everyone, if they might want to just review the two open funding opportunities that we have right now. I'm just looking to see if somebody is on the line, or if, okay, I'm not seeing anybody joining. Then I'll do it, just because I do think, just for everyone's awareness, because I mean, clearly, Councilman Tyler is very familiar with the Provider Relief Fund, but there are there's currently an opportunity to apply for funds. These are, it's $25.5 billion in funding that's available for, across the country, for COVID-related expenses and lost revenue. I see Dara, I'm sorry, I was trying to check. It's hard to see who's here. Anyway, so these two opportunities are currently open. There's one application. The first opportunity is rural focused. And so those who serve rural patients will get higher payments depending on the number of rural patients that they serve. And those payments are based on the billing to Medicare and Medicaid. In addition, there's an opportunity to apply for payments that are tied to lost revenue and expenses. And this is following congressional direction tied to the period of the second half of 2020 and the first quarter of 2021. So July 1 of 2020 through March 31 of 2021. So there's an opportunity to apply for funding there. One of the features that we have built into that funding that may be beneficial to tribes is that we've tried to build in more equity components. So smaller organizations should receive a larger proportion of their lost revenue expenses than larger organizations. Okay, so I see that Danita Hunter, who leads our Provider Relief Bureau, is on the line. I don't know, Danita, I've kind of covered the high points, but if I missed anything or there's anything that you want to add, please, please jump in. Because I do, as I hear some of the comments, I also kind of see opportunities for us to share information that might be beneficial to all the tribal leaders.
No, Diana, thank you. And thank you. Can you hear me, Diana?
Yes.
Okay, great. Thank you. Thank you for allowing me an opportunity to speak. So just a couple other pieces in regards to what Diana already shared. The application is actually open until October 26th. And we also have 2 webinars coming up for those providers that need additional information on the application. Our next webinar is scheduled for October 13th, and we have another webinar scheduled for October 21st. And in regards to the availability of funds, providers who receive funds by December 31st this year will have until December 31st, 2022 to utilize those funds. And so we wanted to share that information with you as well.
Thank you.
Okay, thank you for those responses. And thank you again, Councilman Tyler, for the question. Next in the queue for elected leaders, we have Rhoda Jensen. Is Rhoda with us?
Hi, Rhoda. Are you muted? If you're on a phone line, please hit *6 to unmute yourself.
Okay, maybe we can circle back to Rhoda if we can't get her on. Do we have any other elected leader questions?
Let's see. So, we have a couple of hands, Chairman Wright.
Okay, tribal leaders.
Let's see.
Hello?
Oh, okay, we have Buck Ellingson.
Hi, good morning. Thank you for allowing me to speak. My name is Buck Ellingson. I'm the health policy analyst for the California Rural Indian Health Board and member of the Walker River Paiute Tribe. I'm here speaking on behalf of Dr. Mark LeBeau, CRIB CEO. Tribal health programs are fighting the COVID-19 pandemic on multiple fronts. Besides rising infection and death rates, provider burnout and staffing issues, the Native population in California has no access to emergency, inpatient, or intensive care IHS facilities. This highlights the need for additional financial resources to ensure Native patients can receive timely, acute, life-saving care. CRIB recommends that HRSA provide additional funding to California tribes and THPs to expand access to emergency and acute healthcare services. Regarding the HRSA scoring, we appreciate the tribal set-aside secured by HRSA for tribal programs. If HRSA can work to find a way to make that appropriation permanent, that would be fantastic. However, the current scoring methodology often does not reflect the poverty faced by many California tribes, nor does it address the urgent need for providers in our area. We request that HRSA work with CRIB and California tribes, along with IHS, to create an Indian-specific HRSA scoring system. Additionally, when national data is not available and census data is inaccurate, HRSA should default to a max score for tribal health programs. Moving on to the community health representatives. CHRs provide healthcare, health promotion, disease prevention services to tribal communities. CHRs are great advocates for Native patients because they come from the communities they serve and have tribal cultural competence. The support CHRs provide have reduced hospital readmissions and contributed to lower mortality rates in tribal communities. Additionally, CHRs have been crucial in preventing and mitigating the spread of COVID-19 in tribal communities. CHRs are responsible for vaccine education, outreach, and addressing vaccine hesitancy by debunking myths. CRIB recommends HRSA support the CHR program by expanding training and technical assistance opportunities for CHRs and by providing direct funding for CHR initiatives. Thank you for your time, and we appreciate you hearing our concerns.
All right. Thank you for those suggestions. I think some of them we've kind of touched on the topics already and have kind of set a plan. There are a couple that maybe we'll just have to follow up separately because we probably just need a little bit more info because they're topics that are newer to us. It looks like Chair Jensen is available.
Yes, so we'll go back to Chair Jensen.
Can you hear me?
We can.
Okay, sorry about that. I apologize. My name is Rhoda Jensen. I'm the Chief Executive Officer for the Yakutat Tlingit Tribe. I'm a HRSA TAC member. Good morning, and thank you for your time. I want to circle back a little bit to the HRSA scoring topic that was talked about, and want to just mention that ANHB provided comments to HRSA in their HPSA request for information last year on the HPSA scoring, and we have not seen these comments published or a formal summary or response from HRSA on this RFI. Well, we appreciate HRSA's update today, and it sounded like several comments. Thank you, Doctor, for reporting that to us. We're appreciative to knowing that. But we would like to request that HRSA provide a written summary in response to these comments received during the HRSA scoring RFI request and how they were incorporated. So I have two different topics. That's my first one on the HRSA. And I'm glad to hear that we may take that up when we come for the HRSA TAC, because I think it's very important. My second topic is regarding the CHAP inclusion in the UDS report. Federally qualified health centers are required to annually report data about their facility and patient care to the UDS. This standardized data set includes patient demographics, services provided, clinical processes, and health outcomes, patients' use of services, costs, and revenues. Among other uses, UDS data is used to inform certain funding formulas for quality improvement and determining HRSA scores. We have concerns about how the Community Health Aid Program, CHAP, is used in UDS calculation. We disagree with the agency's recent decision to continue its policy of classifying CHAPs as other instead of as a provider under the UDS data. To put it politely, HRSA is missing out on a lot of data that we could collect. By not fulfilling this counting the work of the CHAPs, we not only undervalue the work they provide, but it also makes the cost of care that they deliver look exceptionally high in UDS calculations. This impacts the ability of providers to adequately access numerous HRSA and other HHS programs that could provide resources to improve healthcare delivery. Any formula-based funding, which is happening a lot right now on how the CARES Act and provider relief is coming out, that uses medical visit counts results in underfunding to tribal CHCs because CHAP activity is not included. We remind HRSA that CHAPs are federally certified medically trained providers whose certification and standards come from the CHAP Certification Board, which is a division of the Department of Health and Human Services that is managed by the Indian Health Service. We respectfully continue to encourage HRSA to add CHAPs to the UDS indicators for healthcare providers, fully representing the work that these healthcare providers do. And just on my own personal opinion, when some of the on-site reviewers have come from the HRSA side, they don't even understand the CHAP program. So we need to have that connection and really make sure that everyone in the federal program understand the value of our CHAPs. They are our providers in our small rural villages. Thank you.
Thank you. Do any of our Bureau of Primary Healthcare colleagues on the line, do you have any responses to some of the detailed issues? Alec, thank you.
Jensen, thank you for your comment regarding the HRSA RFI process and the Make the RFI process. I presume you saw both of those. So you should have received an email that was submitted indicating that your comment was received and that once the FRN was published, you would get a summary of those comments would be included with the publication of the FRN. The Federal Registry Notice. I'm automatically on the acronyms. I apologize for that. As mentioned earlier during my presentation, I think in response to Chairman Payment, we are in the process of working on possibly developing the modifications to those criteria and presenting those both to Dr. Padilla and Ms. Espinosa. And again, as part of the publication of the FRN, we will include a summary of the comments received and an explanation of what led to the recommended or the proposed modifications that we would be presenting. So you would see that in that document. I hope that answers your question.
That's fine. I was actually, I think, because we've done a lot of HRSA, I was trying to get to another topic because she raised a lot of specifics about the UDS. So I thought it was a good opportunity to provide more information if we have it. Alec?
Great, thank you. And thanks for this opportunity to be able to respond. And I think there's concurrences around the board, Chairperson Jensen, that our CHAPs are incredibly valuable to our patient communities. I think an important nuance is worth mentioning, that Pursuant to the Indian Healthcare Improvement Act, the Indian Health Service is charged with establishing and maintaining a federally established community health aid program certification board, which certifies community health aides or community health practitioners, individuals who have successfully completed training in the provision of quality health care, health promotion, disease prevention services to villages served by community health aid program. Moreover, the CHAP certification board published the 2021 Community Health Aid Program Certification Board Standards and Procedures, which is critical to understanding the physician-CHAPS relationship. Under this guidance, it includes that a community health aide or community health practitioner may practice only under the medical supervision of a licensed physician. So if CHAPS are required to practice under a licensed clinician, the policy precludes CHAPS from a general orientation to administer medical services independently, which in current state, under the standards that we follow, is a requirement to being categorized as a medical professional in the UDS. That being said, I think the understanding of the contributions of CHAPS is evolving, and we are certainly following national standards and recognition bodies. If there is a shift or change or evolution in the categorization, we are certainly in a position to make a change in the UDS.
Okay, thank you for those responses. It looks like all the tribal leaders have, we don't have any more questions from elected tribal leaders. So with that, I'd like to turn this over to Melissa Gower for follow-up.
Thank you, Chairman Wright, and to all of our tribal leaders that shared questions and comments today. They were very good questions and generated a lot of great comments. Since we don't have any other elected tribal leaders that wish to speak, we're now going to turn it over to our audience members. So again, if you would like to speak, we ask that you put your name into the chat box or use the raised hand feature, and our NIHB staff will unmute you and you can ask your question directly to our speakers. Also, please feel free to put your question in the chat box if we begin to run short on time. The NIHB staff will be following up with our speakers to make sure that all questions, comments, and recommendations are received. All your voices are important, and we want to make sure that we hear you. I think we have about 20 minutes left. I have captured Jody Werner, Health Director of Ottawa Indians, Steve Cootes from Portland area, and Alita Montiel from Arizona are the three that I have down. If there's others besides those three, please do as instructed. Thank you much. And now I will ask for Jody Werner. If you'll unmute yourself and ask your question.
Honey, can you hear me?
Yes, ma'am.
Thank you. Thank you for allowing us this opportunity today. I want to first say my name is Jody Werner. I'm the Health Director for Little Traverse Bay Bands of Odawa Indians in Michigan. And I am representing our chair, Regina Bentley, today at this consultation. So I appreciate the feedback and support the comments that have been made by the other tribal leaders, and appreciate all of that feedback. What we wanted to focus on, because a lot of the other areas have been focused on, is that our area to make comment on are the provider relief funds. We are in the process right now of finalizing our report that is due, and we were given the 60-day grace period. We have concerns with how these funds have been rolled out and all the changes that were made along the way. And then also the report itself is very invasive, and we feel like it is placing an undue burden on the tribe. There is information asked for in there about, for example, all the funding that we received as a tribe for Corona and virus. And we'd like to know the justification for tribes for that information. We also are concerned about the invasiveness with, for instance, the staffing. By quarter, you want to know all of our full-time, our part-time, our contracted staff, who left, who got furloughed, et cetera. And again, the level of detail seems unnecessary. And I should have started with that we do really appreciate the opportunity to receive this funding. It has helped us greatly during the pandemic. However, the reporting is are troubled by the amount of information that's being requested in the reporting and the changing parameters during the process. It was given to us with a lot of flexibility with no end date. And then through the, since that, I believe that the frequently asked questions was updated 21 times in 15 months, reporting requirements updated 6 times in 12 months. And it's been hard to keep up with. And as we are still in the pandemic, it's disappointing to put this many resources towards a report when we really do need to be putting our resources towards responding to the pandemic. Miigwech for listening to my comments.
Thank you for that feedback, and certainly understand the challenges that folks are facing. I think all the requirements in reporting that you mentioned are tied to statutory requirements, but and so that is the challenge that we face, that we do need to meet the statutory requirements, but also recognize the urgent need and the multiple demands. I will turn it to my Provider Relief Fund Bureau colleagues to see if they have anything else that they want to explain or respond. Danita?
Thank you, Diana. Well, I'm going to turn it over to Stephanie because she's more involved, from the day-to-day in the reporting system. So she has a few comments that she'd like to share.
Yes, thank you, Danita. So just wanted to mention, we understand your concern with regard to the reporting requirements, but we are using this information. You asked what the justification was for the other funding. This, as Diana mentioned, is a statutory requirement to ensure that the provider relief funds are not duplicative of other funding sources, per the statutory requirement that these funds cannot be obligated to reimburse funds that have already been reimbursed. And so that's really what the justification is for getting clarification on other funding that you received and the ability of HRSA to do our due diligence in providing this information and reporting back to Congress. And that's really the justification for the secondary set of elements, those ones that you referred to, like the staffing by quarter, the beds, et cetera. That is another way that we can respond to Congress for the requests and how the funding has been used. So just wanted to provide additional clarification on that, but we do understand that reporting can be a burden, and we're always looking for ways to better improve that. And so please continue to provide your thoughts and input on that, and we'll continue to take that into consideration as we continue to develop our reports.
Thank you all, appreciate that. Next we'll go to Steve Cootes from Portland area. Steve.
Yes, thank you. Can you hear me okay now?
Yes, we can hear you fine. Thank you.
Thank you for giving me the opportunity to speak on some of these things. Many things have been covered, but I want to make a few points, especially regarding the provider. So I'll start with the provider shortage area designations. Irregardless of what your number is, when you compare tribal clinics and IHS facilities to their public neighbors, just maybe a few blocks or a couple miles down the road, we may in fact have similar scores, but we don't have similar success in acquiring providers and staff into our facilities. And I don't really know sometimes what the reluctance is for some of the people to work in the Indian healthcare system, but it's there and it's real. And so I agree with the earlier comments that we automatically ought to have some of those higher scores in all of those areas, because it isn't just money and it isn't just shortage. Sometimes there's other intangible effects on our ability to recruit people into our programs. Secondly, another issue that I wanted to talk about is when you did the CHAP presentation, you said that MDs and PAs supervise CHAPs. Well, our system has way more, and sometimes you may only have a family nurse practitioner in your facility. You're not going to have an MD. You're not going to have a PA. You're going to have a family nurse practitioner. They need to supervise the CHAPs. In the behavioral health system, you're not going to have a psychiatrist. You may have a psychologist. You may have a MSW, Master's in Social Worker. You may have a licensed mental health professional. You may have a SUD professional. Those people should be able to supervise the behavioral health aides. So I'm hoping that in the presentation there, you were just truncating your comments about who was going to supervise. And the last thing I want to do is talk about the use of funds. They come with some very specific language around responding to the COVID epidemic, testing, immunizations. Let me tell you, hiring people to have people in place to address the illnesses and the concerns that people have, especially during this COVID crisis. If they're trying to get their service outside the IHS system, there's huge delays and they're not getting taken care of. And so it's imperative that we be able to use some of this money if we are successful in hiring some people to help provide those services. So I'm asking you what everybody else said here is we need more liberal language around the use of our funds. It's imperative that we have that, and it's imperative that we don't have all of these timelines and delays. And so it becomes very burdensome, and I will admit it becomes very burdensome to figure out how to find all of the answers that you're asking for in some of your questions to justify some of the funds that we're getting. So I want to thank you all for letting me provide these brief comments. Again, my name is Stephen Cootes. I'm from the Portland area, and I'm currently the health clinic director for the Suquamish tribe in Washington State. Thank you.
Thank you. Let me just quickly respond to a couple of the comments you made about the funds, and just the law, the Congress does provide quite a bit of latitude on how you define lost revenue, and that is one of the reasons that the guidance did change, that the definition of lost revenue was legislated and expanded. We do have some resources on our website that might help you if you haven't seen those. Similarly, we have some resources that on the website that describe just the range of personnel related costs that can be considered for the Provider Relief Fund. And there is quite a range. So I just wanted to make sure you were aware of those resources. On your first issue, I was maybe going to ask Dr. Padilla, because I think what you're talking about, getting providers to go work in IHS or tribal sites, is what the Bureau of Health Workforce focuses on, kind of almost across every one of their programs, how to select the individuals and how to prepare them to serve in underserved areas. I mean, that's what Teaching Health Centers does. But Luis, if you have anything to add there, because I do think that Mr. Cootes raises some, important issues that, especially now with so much funding for National Health Service Corps overall, it may even be harder for some tribal sites to get providers because, they can go to other sites that have, lower scores because we have so much funding kind of in the pipeline right now. So anyway, Luis, I thought, and Luis also, has personal experience having been a National Health Service Corps scholar. So anything that you want to add there about strategies to get people to really go to some of those areas that maybe, maybe it is a tougher place to work because of the populations have greater needs.
Yeah, thank you, Diana. And I think this is an important point to sort of stress, and that is that I think the comment and the question certainly from the leaders here are, how do we increase that pipeline? And while we have this additional funding and we've been quite successful in funding all eligible applicants, as been stressed, the National Service Corps is not a pipeline program, particularly the loan repayment program. The scholarship program, I think, our efforts this year have been quite successful with ARP funding. We're going to have over 1,200 scholars entering into the program. That's a 375% increase in that program, which is really an important program to get more individuals into underserved areas. But the loan repayment program is only awarding those clinicians that are already working there. Certainly organizations can use it as an effort to recruit clinicians in there, but it doesn't increase what I think you're referring to is that pipeline. And so as Diana mentioned, throughout all of our programs, we stress the identification, the support of students with disadvantaged background, underrepresented minorities in our programs, to try to encourage and incentivize them to go into these areas after they complete their obligation. And what additional steps we've taken over the last few years is to link up some of our health professions programs to the National Service Corps Awards, providing priorities for those who have completed training in the THC GME program, for example, and the nurse practitioner program, and our addiction medicine program. So we're able to identify those participants that we're supporting in those programs and are now giving them a priority for awards in the National Service Corps. Of course, this additional funding sort of puts that at to slightly a moot point because we're able to fund all the eligible applicants. And I want to go back to what was asked before when we put out about with the Teaching Health Center GME program. So I asked my staff to quickly look at who came in for those development dollars. And we only had, I believe, 2 tribal entities that we can identify come in for that $25 million to establish residency programs. So I think it's incumbent upon all of us to lever whatever resources to identify those organizations, to encourage them to come in, because our efforts are going to continue to be, how do we place our students in community-based settings for those trainings, that education and training, for as long as we can, for as much as we can, support that with the hopes that they will stay in those areas, work in those areas, and lever our loan repayments opportunities to have them go there. The other program that I want to stress that oftentimes I don't think comes up in this conversation is the medical school education program. So this is a program that was established 2 years ago by Congress. It allocated $50 million to, right now we're supporting 10 medical schools across the country. Those schools that have projected to have an undersupply of primary care have a disproportionate number of Native Americans, Alaskan Native Americans, students enrolled in them, and who are have a disproportionate number of recognized tribal entities. And we can certainly provide you a list of those if like people. What we're also trying to do is lever that program with our residency program and our LRP program. So we're doing everything we can to try to create that pipeline, not just of education and training, but ultimately incentivizing and providing opportunities in terms of loan repayment or scholarships to those students that will hopefully go into your communities and work and provide critical services.
Could I have one follow-up comment? I would like to go back to the provider relief funds. When you talk about lost revenues, you only have lost revenues if you have a provider to bill. So if you don't have a provider to bill, you're not going to have any revenues that you're losing. And so the important thing is sometimes you need, I believe we need to have, if we're having shortages or we're having inadequate staff or we don't have the staff to provide those services, we ought to be able to use those funds to put the people in place to then start billing for some of those things that you say we're losing. And so that's one of the, I think that's one of the, you know, the whole premise around this is we want to pay you for the money that you lost. Well, we're losing people's lives. We're losing people in our community because we don't have the people to take care of them. And if you can't use some of the money to put people in place to help take care of them and save people's lives, we're missing the boat on this. So thank you very much.
Okay, yeah, I think maybe I'm not understanding your question, but I mean, you can use the funds to put people in place. Maybe it would be good if our provider relief fund folks just followed up with you separately to find out your specific questions. Now, if you're raising the issue of like, well, maybe you have the funds to put people in place, but you can't find the people that, you know, to hire them, then that is kind of the broader issue, I think, that Dr. Padilla was talking about and that others have talked about, just the importance to build the pipeline, you know, grow your own, you know, recruit people that have that aptitude and that desire to work in these communities. But I'll turn it back to Chair Gower.
Thank you so much. We appreciate the great conversation. We appreciate HRSA so much for helping us. I still did have 4 folks in the queue. We are out of time, so if you will please either put your questions in the chat box, or you can email AC Locklear at NIHB your questions, and we will get those to HRSA and get you a response. So with that, we have come to the end of our time, and I want to thank our speakers, all of the speakers, very much for joining us today, for taking 2 hours and being with us, and to all of the audience who shared your thoughts, comments, and questions during the session. And for that, I'm now turning the floor over to Captain Elijah Martin, Tribal Health Affairs Manager. Mr. Martin. Are you on mute, Mr. Martin? You're still on mute, Captain. There you go.
Is that okay?
There you go. Thank you.
Thank you, ma'am. I appreciate you and all the tribal leaders and NIHB. And as we come to the end of our session today, I want to express how grateful it has been to spend time together to engage on important healthcare issues in Indian country. As I close, share closing remarks, please allow me to thank many who have made today's session and the ongoing years of solid commitment to our agency's tribal health affairs possible. I feel eternally blessed to have been given the opportunity to serve and work with you and for you. It has been indeed my most tremendous honor, a highlight in my public health career, to get to know Indian country and many tribal leaders. For whatever credit is assigned in the success of our agency's response to support the needs of Indian country, I humbly defer recognition to the talented and dedicated OHE tribal staff, HRSA leadership, and HRSA Bureau and office staff. I have witnessed an extraordinary commitment from Michelle Allender, the HRSA Director of Health Equity, the OHE Health Affairs staff, our Acting Administrator, Diana, HRSA Bureau and Office leadership and staff, who have helped increase the level of funding each year to Indian country over the last 10 years. In addition, HRSA's commitment has never been more evident, and Diana's approval of us moving forward with establishing the TAC, which will meet December 1st and 2nd, and an office for tribal affairs. While I will not be a part of that going forward, I want to thank Natasha and her team and the new HRSA IEA for taking on the responsibility for keeping the baton going with the commitment that we have had for over a decade. I want to thank you again for this time that you've allowed us to engage, and we look forward to many great things. The commitment by Diana and the other HRSA staff is unwavering, and I'm sure you will see that as we continue to move forward. Thank you so much. I'll turn it back over for our closing prayer.
Thank you, Captain Martin. We appreciate you, Ms. Espinosa, and the rest of the HRSA leadership team for being here with us today. We will be following up with you and your team on the issues discussed today. We know that having this time is important, and it is also critically important that we track the progress of these recommendations. We trust that the agency will help to support our recommendations, and tribal leaders across Indian country will work to make sure lawmakers also know what our priorities are. Thank you again to our speakers and our audience members. We ask that you please take a few seconds at the end of the consultation to fill out the evaluation. You can find the link that says, please fill out this session evaluation under the description on Pathable session page in the online conference agenda. This feedback is critical for the work that NIHB does and helps us improve our tribal consultation sessions in the future. On behalf of the entire NIHB board, we thank you for joining us for our annual National Tribal Health Conference, and we look to see you in May, this coming May, in Anchorage, Alaska, for our Tribal Public Health Conference. Again, thank you, everybody. Have a good day.